Okay, with that, we will move on from maternal and newborn health to look at child health and child health care seeking. The next presentation is on the validity of antibiotic treatment for suspected pneumonia for that indicator, and the presentation will be given by Harry Campbell. Harry Campbell is a professor of genetic epidemiology and public health and the co-director of the Center for Global Health Research, a WHO collaborating center for population health research and training at the University of Edinburgh. He is the deputy director of the Usher Institute of Population Health and Informatics and co-editor-in-chief of the Journal of Global Health. And so with that, I will turn this over to Harry.
Thanks very much, Cindy. Very happy to be here. I'm going to talk about the validity of the antibiotic treatment for pneumonia indicator. So pneumonia is still a major cause of child death. The latest estimates in 2017 suggest about 840,000 child deaths. And 60% of these are estimated to occur outside hospitals, just reminding us that we need data not just from hospitals but from community-based sources to understand this problem and the impact of interventions. WHO and UNICEF have an integrated global action plan for the prevention and control of pneumonia and diarrhoea. And one of the three prongs is on treatment, and in particular case management at the health facility and community level. So clearly understanding the proportion of children who have pneumonia and receive an antibiotic would be an important indicator to know. Agencies started reporting coverage of this indicator. This is a historical slide from a number of years ago showing here antibiotics for pneumonia and reporting population-based coverage. And this is the context for this work where we assess the validity of that indicator. And we used the approach that Melinda mentioned where we observed children whether or not they had pneumonia, whether or not they were given treatment, and then a follow-up household survey using DHS and mixed questions allowed us to compare these responses to the gold standard to look at the validity of those responses. And we published the initial studies in Bangladesh and Pakistan in the PLOS Medicine collection, and in fact these results were presented here in this room 5 years ago. So just to remind us, the desired indicator is the proportion of young children with pneumonia who receive a recommended antibiotic, and I'm given the numerator and denominator there. But the actual indicator that we can derive from the DHS and mixed surveys are based on a denominator of children reported by a caretaker to have symptoms of a respiratory infection consistent with pneumonia in the past 2 weeks. And I give below there the definition of that symptoms of respiratory infection. And then the numerator is the proportion of those children who are reported receiving an antibiotic. So the project was carried out in Ibadan, Nigeria by Dr. Ayedi, who's with us today here, and Professor Falade at the Department of Pediatrics in the University of Ibadan. And they recruited around 300 children with true pneumonia and 300 children with respiratory symptoms, cough and difficult breathing, but in whom pneumonia was excluded based on an examination by a trained doctor. And then they conducted follow-up surveys with the current DHS and mixed questions. And so in terms of the validity of the denominator, they looked at the sensitivity and specificity of these questions as a measure of confirmed pneumonia or true pneumonia. And in terms of the validity of the numerator, they looked at the sensitivity and specificity of the reports of caregiver recall of antibiotic treatment compared to the antibiotic treatment that was recorded at the consultation. And we looked also at whether this improved with the use of a pill board. So in summary, for the denominator, these are the results of the validity studies in 4 settings: urban and rural Bangladesh, Pakistan, and now this current study in Nigeria. And they all show that the area under the curve is around 0.6, which is below the 0.7 threshold that was mentioned by Melinda. And additionally, the sensitivity, the specific individual sensitivity and specificity values varied quite a lot from setting to setting for reasons that are not completely known. So if we put these 4 studies on our curve, looking at the sensitivity and specificity, we can see that the caregiver report is a poor predictor of true pneumonia. With an area under the curve of around 0.6, the line here of chance is given in the blue line, so these are not very predictive of pneumonia. And the sensitivity and specificity values, as I mentioned, varied widely. So the percentage of true pneumonia will actually vary substantially across surveys, and that will make comparisons across sites difficult. So to try and understand what this means, I've taken the example of a typical household survey that, say, looks at 10,000 children aged under 5. And within those 10,000 children, looking at a 2-week report, you would expect, based on what we know about the incidence of pneumonia, to pick up about 170 cases of true pneumonia being reported in the last 2 weeks, and about 10 times that, about 1,700 cases of children with cough and difficult breathing in the last 2 weeks. So I've put this in a table of true pneumonia present and absent, and then the reported ARI symptoms as reported from the DHS and mixed surveys, and they would be either present and absent. And here you see the 170 children with pneumonia, and then 1,700 children who have the respiratory symptoms but don't have pneumonia. And if we apply sensitivity and specificity values to this, and I'm taking rather optimistic values, rather better than we found in our surveys, 70% sensitivity would give here 119 in 51 of the 170 children with pneumonia, and 75% specificity among the 1,700 children that don't have pneumonia would give 425 and 1275. So in this survey of 10,000 children, there would be 544 that would be picked up as having these ARI symptoms. So of these 544 children with ARI symptoms, 119 would truly have pneumonia. So 22% of those that have been picked up by the survey are truly have pneumonia. So clearly the great majority do not have pneumonia. So let's look at a couple of scenarios. If among these children that have reported ARI symptoms, all 119 children here in the red that have pneumonia were treated with an antibiotic, and none of the children in the purple that didn't have pneumonia, none of them got an antibiotic. In other words, all children were treated correctly, then the indicator value there would be 119 over 544. However, conversely, if none of the children with pneumonia were treated, so none of these 119 children received an antibiotic, but 119 of the children that didn't have pneumonia were given an antibiotic, in other words, none of the children with pneumonia were treated correctly, the indicator value in this circumstance would still be 22%. So I think this is an example of how this indicator does not give useful information on programme performance, and 90% is not an appropriate target value, and indeed could lead in very substantial over-treatment and promote antibiotic resistance. In terms of the validity of the numerator, the pill board was not labour intensive to develop, and that actually in any of the 4 settings that we run the study, and it significantly improved antibiotic treatment recall, with correct recall increasing in the Nigerian study from 63 to 89%, and that was reflected in the overall kappa statistic increase. And we've replicated this now in 4 diverse Asian and African settings. So in conclusion, we have a poor discriminative power of the DHS and mixed questions for identifying true childhood pneumonia, and we've confirmed that now in an African setting. Since most identified cases are not pneumonia, this does not serve as an adequate basis for asking about antibiotic treatment rate. If programmes aim to increase this treatment rate, then they will drive overprescription of antibiotics. So how are the major agencies and initiatives responding to this? Well, the Countdown initiative continues to report on care seeking for pneumonia, which we believe is a valid indicator and is an appropriate thing to do, and they've dropped the antibiotic treatment indicator. So they say that they want to present a careful assessment of how well countries are progressing in the delivery of proven interventions, and only a core set of proven indicators are analysed. And for pneumonia, that seems to be working. However, this is taken from a high-profile paper in the Lancet Global Health this year, actually a very good paper, I think, but it reports on an indicator of antibiotics for pneumonia and says this comes from DHS and mix. Actually, when you go to the supplement of the paper, what they're taking is the care-seeking indicator and they're calling it antibiotics for pneumonia. Whether that's helpful, I don't know, but that's what these data in fact are. World Pneumonia Day was last week, and a high-profile report, a global pneumonia report, was released by a very respected, prominent US group. And within that, they had a set of indicators. And for pneumonia, they have the percentage of children under 5 with what they call suspected pneumonia. And within that, there's a care-seeking target, care-seeking data and antibiotic treatment data. And they mention a target of 90%. So they're using this treatment data to give an indicator on receipt of antibiotics for children with suspected pneumonia. Although later in the report they drop the suspected pneumonia and they just talk about pneumonia treatment coverage. So the percentage of children under 5 with pneumonia receiving antibiotics. And they say this is coming from DHS and mix. So I think that for a high-profile report, this is misleading. It's not really representing the data. So you got a country like Ethiopia here that has 7% as their current pneumonia treatment indicator value, and they've been set a target of 90%. So the action for Ethiopia is to increase antibiotic treatment 13 times over the level that's currently. And I think this is misleading and unhelpful. They mentioned 10 key indicators of success, 7 pneumonia-specific indicators, one of which is antibiotic treatment. So in conclusions, I think because of the low discriminative power and the low pneumonia prevalence, most DHS and mix reported episodes do not have pneumonia, so it's an invalid denominator for pneumonia antibiotic treatment indicator. I think we should not attempt to use these data on reported antibiotics given for symptoms of ARI as a proxy indicator for antibiotic treatment rate of pneumonia. DHS and mix now make their ARI questions very clear and do not attempt to measure this indicator. So they've taken on this information and amended their presentation, I think, correctly. However, as we've seen, some agencies still interpret these data as pneumonia treatment rate, and I think this is misleading and likely to lead to incorrect conclusions and decisions. This treatment report, a pneumonia report, which actually otherwise is excellent, mentions that we can't fix what we can't measure, and we need better quality data, and I think we agree with that. I think that measures of effective coverage of pneumonia treatment should be explored by linking data on care-seeking coverage, which we think are valid, from household surveys, to data on quality of care from health provider surveys, as Melinda was mentioning in her talk. And I think this is an example of where indicator validation studies can be useful in determining which household surveys questions to include and how data should be interpreted, and can give information on how indicators can be improved. So for more details, there's a paper where Dr. Aedi is the first author in the collection, and I'd like to thank the staff of the Department of Paediatrics in Abadan, University of Edinburgh, and Shamim Kazi for WHO, and to acknowledge the funding from the Bill and Melinda Gates Foundation. Thank you.
Any questions for Harry? No questions? Okay, well, thank you very much.
Oh, actually, we have
Oh, is there a question? Yes. Uh-huh.
one coming.
Yeah, so I'm just kind of wondering after your presentation why we should even still measure this. Can you make a case for it, or what do you think?
No, I don't think we should be expressing this as an indicator from the DHS and mix surveys. I think it's misleading and we should stop it. We said this 5 years ago in this room, and I think many groups and agencies have changed, but clearly some have not. And there are some pretty high profile examples of this being used. And of course it's very, we really, really want this indicator, and it's very tempting to formulate it and present it. But I think it's really misleading. This 7% for Ethiopia, I just simply do not believe this. And I think if you had a concerted effort to drive this up to near 90%, it would do far more harm than good. So we need to keep, behavioural change takes time, but we need to keep at this and to stop its use. And I think part of what Melinda's saying is it's not enough just to say this is bad, we should stop it. We need to try and think of a way of improving this. And I think the plans for taking this forward are sensible, and once fully developed will be very helpful, I think.